The purpose of this program is to demonstrate some of the critical factors concerning the body in water and their significance when developing treatment techniques. These factors will first be demonstrated by a symmetrical, able-bodied person, after which some of the applications will be shown in treating two handicapped persons. It must be realized that the body in water is reacting to the element that surrounds it. The reaction is therefore very different to that of the body on land.
When the body is lying in water in this position, it is unconscious of the feeling of gravity and is responsive only to tactile stimulation. First, I hold under S2, and this is a balanced position. By holding under T11, we see the feet drop to 15 degrees and stay. I return the hold to S2. By holding underneath the shoulders, we will cause the feet to drop to the vertical. Working from S2 down the body, if I hold at S2, I have balance. If I hold just above the knee joint at the flare of the femoral condyle, I will get hip flexion. This can be corrected by tactile stimulation of the spine. The hips must be held in position. By moving round the patient, I can hold at the ankles. Now I must not hold at the side of the feet because this will cause abduction of the legs. Holding the patient with one finger underneath each ankle is holding symmetrically. The patient should hold their feet in dorsiflexion. By removal of one finger, we create an asymmetric hold, and the patient must now extend on the unsupported side to hold the rotation. By putting the finger back, we return to a symmetrical hold, and the patient must adopt a midline position. What is done on one side can be repeated on the other side. If the hand is held against the side of the ankle, then a totally different reaction occurs. Where we hold in the water is important.
Here, the symmetrical holding on a hemiplegic is demonstrated. Whenever we apply the symmetrical holding to a hemiplegic, the patient can also maintain his position.
And so by first holding on a symmetrical hold, he can maintain the position. First we hold on the one side, and this rotation he can obviously control. But when I change to the other side, he will have more difficulty. Stretch the arms, both hands in the water, hands in the water. By leaving the hands out of the water, he can control the rotation. Hands in the water. glabellar reflex can be demonstrated in full. If I touch between the eyes, we get extension of the hips and the feet drop. If I touch in the occipital area, again we get extension of the hips and the feet drop. If I touch on the cheek below the left eye, the body rotates to the right. If I touch below the right eye, the body still rotates to the right. From this, we can conclude that we must not touch the head. The model is asked not to move her head, but just look at this object with her eyes. If the object is held here, extension occurs with the feet dropping. If the hands are taken around in the water above the head, we have the longest shape of the body, which is now responsive to lateral flexion and lateral rotation. With this patient, we want to change the working situation so that we can get lateral flexion with lateral rotation. Therefore, we must work in the longest position that he can adopt. Bring the arms over the head, Heine. Stretch at the hips. Push the feet down. Bring the hands around to the side, and now the legs apart, and the body now is in its widest shape, the critical point being extension of the hips. The body will now rotate around the shoulder girdle. The body has rotational patterns within itself. What is not generally realized, that these patterns are extended to outside of the body to control itself in space. Bring the hands out sideways, and we shall see one of the most common patterns used by the body in water. When the arms are extended sideways, the radius from the midline is greater, and therefore exerts greater control against rotation.
The patient is asked to stop the handicap-induced rotation. At first, this is facilitated by making use of inertia patterns. It is striking that the patient also stops the rotation automatically, using metacentric effects. The body knows how to move. The model is asked to check the deliberately induced rotation by highly volitional movement. This volitional movement arises on the basis of asymmetric tonic neck reflex in a situation in which the balance of the longitudinal axis of the body is endangered. This movement can be regarded as an inertia pattern, blocking the rotation, and is accompanied by homolateral eye movements.
And here we see the classic movement referred to as an asymmetric tonic neck reflex, which is an inertia pattern blocking rotation. I will ask the model to hold her hands at her side with the elbows in, holding tight to her side. Now, will you please keep your feet together and swing them to your right? And we can see, while she inhibits this movement, she cannot swing the legs to the right. Now, will you please swing them to your left? And we can see the difficulty that she has. Let your arms come free from the side. Swing your legs to the right. And with the arm free, she can make this movement to the left. Swing your legs to the left. That's right. To the right. To the left. From this we can also conclude we must never hold the arms. If any part of the body is taken out of the water, the body will be caused to rotate to put that part back in the water. Lift this hand out of the water, and we see rotation occurs.
This patient, suffering from an incomplete spinal cord injury, tries to use his non-paralyzed low back muscles.
Fine. Keep this hand in the water, raise that hand as though you are pushing. Stop the rotation. Stop it. Stop it. Push with the shoulders. With the shoulders. That's right. Hold it. Hold it. Hold it. Hold it. Keep the feet down. Push the feet down. Feet down. To demonstrate a combination of metacenter and muscular conditions, we ask the model to sit with the hands forward, back upright. Now put your hands in a pushing position, and we will see that the muscular activity is taking place and the body is falling forward. Put your hands in a pulling position. And here, despite the metacentric principle, the body is falling backwards. Put the hands in a pushing position. Now hold the body. Do not let it rotate. Change the hands to the pulling position. Hold the body. Do not let it rotate. Change the hands over slowly. To see the effect of this movement, we will ask the model in the sitting position to take one hand sideways and put that hand out of water in the pushing position. Now we shall see a disturbance of posture, which she must try to correct. Take this hand sideways. Bring the body upright, the back vertical. Lift your left hand.
The patient is asked to raise the left hand and to maintain position against the disturbing influence of metacentric effect. Control of the position is initiated from the head. This is essential, especially when it concerns water altitudes above the 11th thoracic vertebra. The patient must really push against the water. The movements have to be slow and small, however, in order to prevent counterlateral balance disturbances.
Too fast. Hold it. Hold it. The model is asked to extend the arm sideways and one leg sideways to stretch the arm and leg. Think about that movement. Stretch. Can you feel it? Yes. Stretch hard. Can you feel it? Yes. Put the arm and leg back again. Now do not create the movement, but just think about it. Just think about it, but on this side.
We will again briefly demonstrate the consequences which the working on rotation control can have. The patient is asked to maintain position against the disturbing influence of metacentric effect. Partly due to the loss of tone, which is quite evident in the left leg, the patient is able to maintain the legs in a normal position. Moreover, after some time, the patient can abduct the legs actively. This is impossible outside the water.